Okay. This is our last official Zoom class for content. Can you believe we're this far? It just seems like it flew by. It's just hard to believe that we've gotten through everything except for this last content. So chapters 4 and 5, we don't talk about a whole lot in this class. Some of the information is at a higher level, but there are a few things that you need to know. So grasp what you can and take some notes. I just posted these at like 1:30 or 2 o'clock today. I didn't expect you to look at them anyway. So we're going to talk about infertility a little bit and contraception. At the very beginning of the quarter, we had discussions about the unplanned pregnancy rate in this world, which is about 50%. And it's really surprising in this country that we have such a high rate of unplanned pregnancies because there's so much resources out there for women and men to help prevent unwanted pregnancies. The methods of contraception are varied. There's a lot we can do, a lot of good choices out there. And so it's just lack of knowing, okay, knowing what's available, cultural aspects of contraception, spiritual aspects, and just a lot of different things, and all the, of course, political issues going on right now, and that will probably forever go on because there's no quick resolve to preventing pregnancy, or what is the resolve to an unwanted, or an unwanted pregnancy is not, or I should say it this way, an unplanned pregnancy is not necessarily an unwanted pregnancy. Okay, so let's begin by talking about infertility. About 1 out of every 8 women have problems conceiving. Okay, it could be a lot of things, but we usually investigate the female prior to investigating the male. Okay, so let's talk about it a little bit. So this week, let me just take a break and talk about what you're doing in class this week. So you only have one assignment this week, and that's the in your module week 9, the HESI RN maternity assignment exam. There's 2 of them. There's an assignment exam and a practice exam. They're longer. Okay, take your time doing them, but do well. Okay, they only have a 1% value, but they're valuable for study. Okay, for the HESI. Okay, so next week is week 10. We're going to be preparing for the HESI. So we'll have class, but we're just going to cover all kinds of content and go over the things that from the past, because the HESI is comprehensive. Okay, so we've got a lot of work to do this next week. Okay, so 10 to 15% in couples. Okay, as far as infertility, it's not considered, a woman's not considered infertile or have difficulty unless she's been actively trying to get pregnant for a year. Okay, after a year, then we've got to do some investigating to see what's going on. So we need to make sure we provide accurate information to our client and her partner, her boyfriend, or her husband, to see if we can identify what's going on that could be not allowing them not to conceive. Okay, these people need a lot of support. They need a lot of emotional support, and we need to give them options. Okay, so first thing we do is get a good medical history. Okay, family history and her own history. We do some testing, endocrine levels of progesterone and estrogen, and then we can do an ultrasound to look at her anatomy, There might be something in her anatomy. We also can do what's called a histosalpingogram, which is injecting dye into the uterus and watch it flow through the tubes so we can assess the patency of the fallopian tubes. Okay. She might have a metabolic disorder like PCOS and have irregular periods. PCOS, they also have high levels of estrogen and not a high enough level of progesterone, so hormonal imbalance. Once we've done all the investigation we can for mom, we do want to check the partner out. Okay, it might be his sperm. There might not be enough. There might not be enough semen. The quality of the sperm or the quantity are both important. Sometimes drugs, if you have either the female or the male is on some kind of opioid or some kind of methadone, maybe they're in methadone treatment. Those kinds of drugs reduce the ability to conceive, especially for a male. Okay. And then, of course, chronic diseases like diabetics. Here's just a picture, and I think this is in your book, something similar to this. I got this from Up to Date. But the uterine anatomy sometimes prevents conception. Sometimes the uterus is just half its size with one fallopian tube. So there's a lot of different reasons. I've taken care of women that have the didelphys, where they have two uterine bodies and two cervixes. Usually pregnancy will occur on one side and the other side is usually non-functioning. Okay, but this could be a reason of not conceiving. Of course, for the male, then not only we do want to look at testosterone levels as well as a semen analysis. Okay, might be some other testicular factors, so we could do an ultrasound of his testicles. Okay. And of course, there's just idiopathic. If he has some kind of genetic mutation like Klinefelter, he can't conceive. I kind of talked about this already. It goes into all the different things that we can do for the woman. So let me give you a story of a young woman, and it happens to be my daughter. Okay, she had been married for 6 years, and they had been trying a long time to get pregnant. And we had found out, it's before she was pregnant, we found out that she had a bleeding disorder she got from her father, from me. It was Leiden factor 5. People with Leiden factor 5 mutation, it's one of the coagulation factors, make blood clots very easily. And what was occurring was she was having heavy periods and they were uncomfortable. She didn't have endometriosis that we know of because it didn't seem to be that bad, but she's trying to conceive. And so they decided to do a diagnostic laparoscopy. Okay, this is just using a laparoscope to go in and visualizing the ovaries and the uterus and the fallopian tubes. So this is almost a last ditch effort. So they went in and they looked, and she had all kinds of endometrial implants. In other words, she had endometriosis, but a very mild form. And she had a lot of blood clots on her ovaries, which prevented her from ovulating. So what they did is they cleaned all that up. What they do, they burn, fulgurate, they call it fulgurate, burn all those little implants, the blood vessels. And then she became pregnant and had 4 kids later, or she ended up having 4 children. So it worked out for her. But this is just one way. If you can't figure out, sometimes we'll just go into surgery and look at what's going on. So this is just some pictures of how they do that. And you can look at that at your own time. So nowadays we do a lot of in vitro fertilization, millions of them a year. It's very common now. It's very safe and very successful. I don't know if you remember though, there's different kinds. there's embryo implantation, there's zygote transplantation, and I don't even know all of them. Okay, but there's all kinds of things that they're doing now to help women conceive. Remember that women who have assisted reproductive procedures, they're more likely to have difficulty during the pregnancy. Okay, they're going to be more than likely to deliver preterm. Okay, more than likely to have preeclampsia. So these are the risks associated with this. Here is a video that you can watch that shows you fertilization assessment, and it's a microscopic view if you want to watch that video. It's kind of interesting. I do have a few videos in here that you can watch. And then here's another one that shows you a laparoscopic device where they're assessing the tubes. And of course, there's other options: surrogacy, adoption, cryopreservation, okay, freezing embryos. A lot of embryos are frozen now, and it works. And I don't know how it works, but it works, okay? So surrogacy is, so this is why this couple needs a lot of support. If they go the surrogacy route, there's a lot of emotion involved with that. There are actually companies out there that, or agencies, I should say, that provide, they have a registry of women that you can get to know, or you can connect with, that will be surrogates. And I'm not sure how it works. I do know that I had a woman as a client who was a surrogate. And so when she came in for her exams, all the information that I collected, all the tests and the labs that we did, we sent to the agency. They have the right to have all the medical information for the client. Okay, so it's a fascinating field, and it's certainly needed, but it takes special people to be able to do that. Okay, and then there's all kind of fertility awareness methods of contraception, non-hormonal. Okay, being aware of knowing a woman knowing when she ovulates. If she has regular periods, she probably ovulates regularly. And so there's a way of measuring ovulation, temperature, um, uh, cervical mucus assessment. So knowing when she ovulates, then she can, okay. Cassandra had trouble with her camera, and that's why she got started late on her exam. Okay, so so you can use that form of contraception. If you know when you ovulate, you're going to avoid intercourse. The egg is viable for 24 hours. Okay, so if she knows when she ovulates, she needs to avoid intercourse at least 2 days before and 2 days after, because a sperm can live up to 72 hours, 48 to 72 hours. Okay. And then, of course, coitus interruptus, which if couples use this, they need to know that sometimes when they interrupt sexual activity, it doesn't mean that the male didn't ejaculate some. Okay, it's not a for sure method. But if that's a method they want to choose, by all means, they should. So we need to, be non-judgmental, helping them think through the options of contraception. Predictor kits, the LH prediction. LH is the luteinizing hormone that is sent from the pituitary to the ovary to tell the ovary to release the egg. In other words, it tells us that ovulation is going to occur within another 24 hours. So if she uses a pregnancy kit, LH kit, then she knows if it's positive, if the LH levels are high, she knows she's going to be ovulating the next day or so. Breastfeeding is not a reliable means of Contraception. I've taken care of too many women who come in to me at 4 months postpartum breastfeeding a child and they're pregnant. Okay, they're pregnant. So it's not a reliable predictor. And then there's barrier methods. Okay, these are non-hormonal. Okay, just devices that put a barrier between the sperm and the cervix, basically, to put it simple. So it takes this. Some of this takes education. Cervical caps, I think those are available over the counter, but we still want to educate the clients how to use them. And it's always best to use a spermicide along with a cervical cap. A diaphragm is another choice. And knowing how long that cap or that diaphragm needs to be in place before we remove it. So a diaphragm needs to stay in place after intercourse for at least 6 hours. So there's a lot of education that goes along with these, and diaphragms have to be prescribed. Okay. Contraceptive sponges. I'm not even familiar with a lot of these. I deal more with hormonal methods because these are cumbersome, right? They tend to be non-romantic. Okay, so unless your client is going to be compliant, a hormonal method might be a better way. But then there are some clients who can't take hormones. Does anybody know the World Health Organization recommendations for hormones? They have a chart that will guide a woman in what's the safest hormonal method for her, or contraceptive method. Is anybody aware of that? So do you know of when a woman should not be on any kind of hormonal birth control? What are their problems? What are their health problems? Anybody know? Okay.
Bleeding risk?
Okay. Blood disorder. Yeah, some kind of blood disorder, maybe. What else? If you're talking, Crystal, you're muted. Okay. Okay, a client with diabetes.
Oh, that's a cancer.
Cancer, yeah. Because people with cancer, people with diabetes, they make blood clots easily too, and we do not want estrogen given to those women. Women with seizures, seizure history, no hormonal. Lupus, migraine history, no hormonal contraceptive. Now, progesterone is a little safer. And some, if we have a woman with a seizure history, if it's okay with their neurologist, we can use a progesterone only method, and that's safer than with combination with estrogen. Most birth control products are made either progesterone or a combination of estrogen and progesterone. So if we're giving them these hormones, it tells the brain that she has plenty, so she's not going to ovulate. Okay. So there's oral contraceptives, it's probably a very common, but women tend to forget them. Okay. There's transdermal or patches methods, and then there's rings that go in the vagina that have a combination of the two. Okay. There's also progestin only methods, or the Depo-Provera, or the Depo-Provera is what we call it, and most lay people call it the shot. This will put on weight, but it is safe. And we use this a lot for women that have cognitive challenges, women that are not independent. They have some kind of cognitive brain delay of development. So I had a client bring their daughter in who was 14 years old, and she was just cognitive, cognitively challenged, and she had trouble taking care of herself. So she wasn't learning how to take care of herself, and she was having periods, and it was just, they said it was just horrible. And so we came up with giving her a higher dose of the Depo-Provera so that she wouldn't have any periods. Okay. So we did that every 3 months and stabilized her, and it worked out really well. And then we dropped the dose a little bit. So she didn't have any periods, and it was much better for her lifestyle and her parents. So we could do that. The next Planon, or it's called it's a progesterone only subdermal implant. We can put this in the office. We just numb it up, and it's like a little gun. It shoots the hormone in. It's like a small, about a little over an inch long and maybe just a millimeter wide implant. It's almost like a soft Q-tip. Okay. And that's good for 3 years. And so at the end of 3 years, I can make just a little incision and pull it out. The next Planon is safe, and it's a good choice for women who don't want IUDs. Okay. So young teens, this is a good choice. Not going to gain weight. Periods can be irregular, and it can be frustrating for a while, but once she has it in for a few months, it usually regulates. And then we can also do intrauterine contraception. It's been around forever. There is a non-hormonal contraception. It's called the Paragard. And I'll show you a picture of it. This is available through a lot of county health departments. If someone's on a limited income, they can go in and get a Paragard. And the nice thing about the Paragard, it's effective for 10 years. Okay, she's going to have periods with it, but it's still protecting her from pregnancy. And then the other form is called the Mirena. That's a brand name. It's got progesterone in it, and it depends which kind you buy. It's good for 5 years or 3 years. So these are very safe, and I use IUDs for women with fibroids. They're finished having children, and they're having heavy periods. So we can do an IUD to reduce her bleeding. And even though she's not interested in having more children, but because of the fibroids, it helps control bleeding. So here's a picture. On the left is the Paragard. You can see that it's a shape, both of them are the shape of a T. The Paragard has copper wrapped around the stem. Copper is a spermicide. It will kill sperm. Okay, so that's how it works. So the IUD is inside the uterus, and when the sperm travel into the uterus, the copper destroys them. It's not 100% guaranteed, but it's pretty effective, and it's a good option. In some of the other countries that maybe don't have the resources, they use a lot of the copper IUD. I used to take care of women from the Middle East in my practice, and they would come in for an exam, and they have the copper IUDs. And then the Mirena, or the Kylena, or the Skylena, Skyla. These are the hormonal IUDs. I just love these. I always talk anybody into one of these. I put one of these in a 13-year-old before. She was game for it. Her mother said yes, and I thought it was perfect for her. I used a smaller version, and she did super, and she was protected for 5 years, and she didn't have any periods. What's nice about this form of birth control? It's safe. Progesterone helps protect against endometrial cancer and ovarian cancer. So the myths that you might have heard in earlier years are not true. Okay, so these are good choices for women.
I have a question.
Yes.
On the IUD, it says you don't get periods, but what if you still get periods? Is that a thing?
Yeah, it might happen, but they're usually regular. They're usually regular, and usually they're good for 5 years. So a woman might have a period for a year, but then it might begin to slow down. Yeah. Does that answer your question? Okay. Any other questions? Okay. So this is just a sheet that is really good to have in the office, or give it to your children, or keep it yourself, give it to a friend. Anybody that's on oral combined birth control pills, OCPs, if they miss a pill, what should they do? So it's like an algorithm. If they miss a pill one night, if they take it every night and they miss it one night, take it as soon as you remember to take it. You still should be okay. If you miss 2 pills during week 1 of your cycle, so there's a 4-week cycle. If you miss 2 pills during that period, you're going to take 2 pills for 2 days, and you want to use a backup method for seven days. So this is a great form. No reason to memorize it, but it's great. I used it a lot, and I don't have it memorized. So it's just a great form to have to inform someone who missed a pill, or if she's missed 3 or more pills, what should she do as far as birth control? Emergency contraception. Now you know what's going on in the political arena. They're taking misoprostol, and they want to take all these emergency contraception methods off the market. But emergency contraception is that if a woman has unprotected intercourse, if she takes high doses of the combined estrogen and progesterone for 3 days or so, it depends on which one she's taking, she can help prevent a pregnancy. And then, of course, the levonorgestrel, which is a progesterone, take 2 days of that, and that helps prevent pregnancy. Or we can just go ahead and put a copper IUD in, but we've got to do it within 72 hours. Okay, we don't want her to say, I had unprotected sex, and then 4 days later come to the office. No, we need to know as soon as possible. We can kind of help prevent. And then, of course, permanent sterilization. If a client doesn't want children, or she's finished having children, or she just doesn't want children, then we can actually do a permanent sterilization. So for a female, it's clamping the tubes. For a male, it's interrupting the vasectomy so that the sperm are not released. Now he'll still produce semen, but there's not going to be any sperm in it. So both of these methods are surgical. The male can be done in an office. The female requires general anesthesia. So it's a little more serious. Now you're not going to talk a man into saying it's not serious. It's serious on both ends. Okay. But they can be reversed. Okay. We can reanastomose or reconnect the ends of the fallopian tube together again, and very successful at doing that. They usually just do one side, okay? Reversals. Women don't have trouble getting pregnant after a reversal, and men can have more children. So the nice thing about it, we can do these procedures in a way that, yes, it's permanent, but we can reverse it. Okay, not always successful, but a lot of times it is. Okay. And this is just a picture of the procedures. Now, there have been cases that they reconnect and grow back together on their own. I had a 46 years old. Did I share this before? 46-year-old woman and her new husband. They both were fixed earlier in life, after they had their children, and she got pregnant at 46 years old. It's because both of them naturally rejoined, and so they had a baby at 46, healthy baby. but it was quite a shock. Okay. And then the abortion, the methods of abortion. It's a state-by-state decision now, whether the state allows first trimester abortions. Second trimester abortions are a no-no, I think, everywhere now. So basically, it's the same thing as doing a D&C, where we dilate the cervix and we go in and remove the fetus or the embryo, however far along she is, placenta and everything else. We also provide, after the procedure, methotrexate, which also will reduce the growth of the embryo. It's and we use it along with misoprostol sometimes. So there are different forms of preventing or providing a medical abortion, surgical or medical abortion. Okay. Methotrexate is a folate antagonist. It will stop, it will not allow that baby to grow. It just stops. And then mifepristone is going to cause contractions and open up the cervix. If this is an area, if you're in OB and you like OB and you think, I have had students take this class and really like the field, and they end up going into wanting to work for Planned Parenthood because Planned Parenthood pays well, is what she told me. But you have to be really careful if this is where you want to go. You have to consider your own personal values. So you need to sit down and do some self reflection before you go into this field. Know your state laws. I know it's hard to stay up on all that because of the changes. You don't know week from week what's going on, but you really need to know before you engage in that field. So the first trimester abortion, I'm talking about surgical abortion, medical abortion, is usually the safest and the less complex, but we still can see complications from it, infections, okay, retained products. And we didn't get all of the placenta out when we did the surgical abortion, not all of it, and it can set up an infection. It's causing scar tissue, causing excess bleeding, and then damage to the reproductive organs. Okay, we'll end up with these slides with a question. This is a scenario, you might say. Physician prescribes clomiphene citrate. Now, clomiphene citrate, Clomid, is the estrogen stimulator. Okay, what it does, it helps women produce more eggs, or I should say more follicles. Okay, for women that are having trouble conceiving, we can give them Clomid so many days out of the month. She's very concerned, this client. So the provider is going to prescribe this medication for her. We educate, we give them a stack of material to take home and educate them. But she's expressing concerns that she's going to have twins or triplets. What would you say to your client? Which one do you think would be the best one?
Hey,
Yeah, so we can't say that no one has ever had triplets because it could have happened. Okay. Ovulation will be monitored on the ultrasound, but we can't prevent it from happening. Okay. And then the last one is really poor. 10% is a very low risk, so you don't need to worry. Well, 10% is 10%, right? So the answer is A. Okay. Any questions about any of that? So very general, okay? Very general. I know you won't be tested on that, but it might be on your HESI, some of the information. Now, let's talk about some problems, reproductive concerns. So you'll probably be going over some of this stuff when you take pediatrics, unless you're already taking it. Puberty. What is the first sign of puberty in women? Anybody know?
With the breast buds?
Yeah, breast buds. Exactly. And so usually we like to see breast buds before age 13. Okay. Because usually what follows 2 years later is then when they have their first period. So breast buds, 2 years later, menarche. Okay, breast buds, it's called thelarche, and 2 years later, menarche. That's usually the typical time period. So, but if you have a client that she has not developed breast buds by the age of 13, then we need to investigate. Or if she's not had menarche by the age of 15, we need to investigate. Or if she's had breast buds, but menarche has not presented itself yet within 5 years. So these are concerns. What's going on? That hormonal problems usually. So the Tanner stages, I know you learn it in pediatrics. So breast buds is considered stage 2 of the Tanner stages. Tanner stage 1 is pre-puberty. So you're going to have breast buds and maybe a scant pubic hair. Okay, so amenorrhea, if she doesn't have periods, no periods, primary means she hadn't had a period and she's 15 years old already. Okay, there's a lot of different reasons it could be. Just anatomically, there's an obstruction, outflow obstruction. Sometimes we have to do surgery to correct it. Hormone imbalance, PCOS. PCOS people have, like I said, excess androgen, hypothyroidism. And so that upsets the other hormones. Genetic reasons, Fragile X, Turner syndrome, chronic diseases, diabetes, celiac disease. Anybody know what celiac disease? Have you learned that in GI? Certain foods can't digest well. Okay. Eating disorders, anorexia, malnutrition, medications, alcohol, anti-epileptic drugs, chemotherapy, of course, contraceptives. Usually amenorrhea, it means that she's pregnant. Okay. What was I going to say? Also, that's not on here are athletes. If you have a really an athlete that's training for the Olympics, very aggressive, she might not have periods. So this is just a picture of what we call the hypogonadotropic amenorrhea. In other words, the hypothalamus, the pituitary, and the hormones, stimulating hormones to the target organ. There's an upset in this feedback system that that doesn't allow for menstruation. You don't have to have this memorized. But just knows that hypothalamus will spit out a gonadotropin hormone, and then that goes to the pituitary. Pituitary then spits out the FSH, the follicle stimulating, and the luteinizing hormone to the ovaries. Okay, and they produce estrogen and progesterone. Estrogen and progesterone are needed for pregnancy, right? There's a really good video in here about that cycle. They make it a lot simpler. Okay. So some other problems besides amenorrhea is premenstrual syndrome. And it's during the luteal phase, right before the period. That's why it's called premenstrual. The client has not only physical symptoms, but psychological symptoms, behavioral issues. She tends to retain fluid, bloating, food cravings. So we usually guide women who have this, let's look at what you're eating. Let's change your eating. Let's talk about good old exercise. And we can also treat PMS with birth control pills to rebalance her out. Sometimes that really helps. But then there's a worsening. It's called a premenstrual dysphoric disorder. This is just a worsened PMS when we're talking about really bad headaches and bloating, mood swings, depression, anxiety, irritability. It affects the woman more, it's more prominent in her life. In other words, every month she goes through this. We're not sure about the causes of this, but once again, we do the same thing. We talk about nutrition, lifestyle, exercise, maybe even some psychotherapy, some counseling might help, or medications. I know for menopausal symptoms, it's similar, but with menopause, all the hormones are dropping. And so a woman does go through a lot of mood changes. And we can treat her with certain antidepressants. Paxil is a good choice. Paxil, however, it's a antidepressant, but it tends to a client tends to gain weight, but they might be able to tolerate things a little bit better with an antidepressant if they're experiencing the dysphoric disorder. So it's a comprehensive plan. So some other terms that would be good to know. Dysmenorrhea means painful periods. Okay, just like dysuria means painful urination, dysmenorrhea means painful periods. Okay, so it occurs usually right before menstruation and through menstruation. Prostaglandins are prominent during menstruation, and that's why you have a lot of the cramping that goes on. So we give antiprostaglandins or NSAIDs. Naproxen is a good drug of choice for dysmenorrhea. If a woman smokes nicotine or she's obese, it's going to be worse. Okay. Obesity, adipose tissue is inflammatory tissue. Okay. So primary dysmenorrhea, prostaglandins I mentioned, just like when vasospasms, or when the blood vessels are constricting and releasing, they're spasm, right? Sometimes around the heart, the coronary arteries can have spasms, right? And it causes pain because it reduces blood flow. Well, the same thing with the uterus. And when the arteries spasm, it's painful to the uterus. Okay, so that's what dysmenorrhea is. So we can use naproxen or ibuprofen. Heat, maybe encouraging her to increase a little bit of her calcium, reduce caffeine, exercise. I know she's hurting, but if she can walk, it'll help improve the blood flow to the uterus. So that's a dysmenorrhea. There's a secondary, in other words, something is causing the pain. I think mainly of pelvic pathology or infections, or congestion, pelvic congestion syndrome. We always start out with an ultrasound. Okay, it's basic, just to look at the anatomy, see if there isn't anything going on. And then we might want to do a biopsy to see if there's something else more serious going on. And then a laparoscopy would be the most invasive thing to do to remove the underlying pathology. So for example, endometriosis, okay? So endometriosis, endometrium is the inner lining of the uterus. And it sloughs off during a period, right? Well, sometimes there's overgrowth of the endometrium, even when the woman is not on a period, and it's released out of the uterus, and it makes little implants in and around the uterus, around the ovaries. And this is called endometriosis, and it's very painful. Okay. We can't diagnose this unless we do surgery. Your client might have all the symptoms of endometriosis, but we can't diagnose her unless we do surgery. Okay. They have deep pain, deep pelvic pain. Dyspareunia means during intercourse, deep penetration hurts. Okay. Painful intercourse. So we can give medications, or we can go in surgically and burn all those little escaped implants, those little red areas in that picture. Here's just another picture of it. You can see it's pointed to all of the areas, and they look so small. How can that cause pain? But it does. It causes a lot of pain. And then the different kinds of bleeding, irregular bleeding, okay? Oligomenorrhea, small amount of bleeding, very short, scant periods, or hypomenorrhea. Menorrhagia, heavy bleeding. Metrorrhagia means irregular bleeding. And then abnormal uterine bleeding, usually associated with fibroids, okay? Fibroids, women tend to grow fibroids in their late 30s, early 40s. These are estrogen dependent, okay? So we can use progesterone to control the bleeding that these cause. Or we can remove them, and we call that myomectomies. I actually had a client that was in her 30s and got pregnant with fibroids. She was really uncomfortable the whole time she was pregnant, but she did well. We ended up having to do a C-section. Okay, and so let's talk about the last slide. The rest of the slides are talking about sexually transmitted infections. So the vaccine for HPV, which is the human papillomavirus, called Gardasil. Okay, we really try to promote this, try to get pediatricians to promote this, because this protects a client from cervical cancer. Okay. So usually age 9, now we can give it to boys and girls, and then repeat it again in 6 months to a year. But if we give it when they're older, we have to give a second dose, a booster. They've actually approved giving this up to the age of 45. We're seeing more HPV in older women now. Chlamydia is the very common microorganism bacteria that can cause infertility, can cause premature delivery, can cause serious infections because it spreads so rapidly. It's easy to treat. We just have to teach routine checkups. Get checked. If you have a client that has several partners, sexual partners, she needs to be checked every 6 months for HIV, any sexually transmitted infections. She needs to be taught what they look like. And just some ugly pictures you can look at. Gonorrhea. Gonorrhea is like syphilis. The symptoms might go away, the discharge might go away on its own, but it does spread throughout the body. It can be disseminated like syphilis. and it causes like an arthritis in the joints. It manifests in arthritis in the joints. Trichomonas is another one, easily diagnosed underneath the microscope. Syphilis, initial infection, it's called a chancre. It's painless and it goes away on its own. If you don't know it's syphilis, then you don't realize what's going on. If you don't get treated with penicillin, it's disseminated and can actually cause neurosyphilis. Okay. And the secondary manifestation is a rash, palmar and plantar rash. Babies that were exposed to syphilis in utero, they're born usually with a rash. Treat with penicillin injection, intramuscular injection. And this is just more pictures. Pelvic inflammatory disease. I know with some of you, I can't remember what class, but I think pretty sure we talked about the client that showed up in the ER, young lady, and she's having severe pelvic pain. And we went through all the differential diagnoses it could be. Is it ectopic pregnancy? Is it a molar pregnancy? Is it pelvic inflammatory disease? Or is it a molar pregnancy? There's so many things it could be, okay? But I can tell you, any woman that shows up at reproductive age with severe pelvic pain, everybody assumes it's PID, pelvic inflammatory disease. Having so many microorganisms in and around her vagina and her uterus that could spread into the tubes. Usually we'll get a CAT scan. An ultrasound might show some inflammation, but a CAT scan is going to be more definitive. So it's also called a tubo-ovarian abscess. So pelvic pain, you might even be able to palpate a mass, fever and chills, of course, discharge, abnormal bleeding. White blood cells are way above 10,000. So usually it depends how bad her white blood cells. We do IV treatment of a couple different antibiotics and might keep her for 24 hours. And then we send her home on oral medications for a while. Education, education, education. She needs to understand what's going on. Okay. That infection can cause infertility or ectopic pregnancies. If she's had PID, she's got scar tissue in her tubes, she can, when she gets pregnant, she could actually have an ectopic. And this is, I think this is up to date. They change it every once in a while. The CDC changes how we need to treat it. But you notice it's cephalosporins and then the broad spectrum antibiotic called doxycycline. And there's a kitty cat. Herpes, this is a virus, right? Once you've contracted herpes, you always have it. It does tend to remain dormant in the spinal roots of spinal nerves. So what makes it become active again is usually stress. So there's that breakout of vesicular vesicles, painful vesicles. And HSV 1 and 2, you can find them both orally or on the vagina, on the genitalia. We can treat with some valcyclovir or acyclovir when it's occurring. It doesn't cure it, but it might make it shorten the outbreak a little bit. And then if a woman has a lot of outbreaks because she's got a stressful life, we can actually treat her routinely, prophylactically. She can take even in pregnancy. So if you have a client that comes in who's pregnant and she tells you that she has frequent frequent herpes outbreaks, we're going to put her on valcyclovir. It's a once-a-day dose during her pregnancy. It's safe because we don't want it becoming active during her pregnancy because the baby can be affected by herpes. Okay. And there's some pictures of what it looks like. It's pretty common. Sometimes women come in, they don't realize they've been affected with it because they don't have any outbreaks. So if we do a test and it tells us she's got HSV antibodies, that means she's been exposed. Then you have to tell her. And that causes problems because if she brings her partner in, then it's the blame game. So that takes a little TLC to help them work through that. First thing I tell them is when I say it and they look at each other and get mad, I say, this is not a blame game. We can't do that. That doesn't work that way. Hepatitis B, familiar with that? That is another blood-borne antigen exposure. And if you work in healthcare, it's recommended you be vaccinated against it. Newborns are vaccinated. What age? Does anybody know when a newborn or a baby is vaccinated with hepatitis B? Is it 6 months? Anybody know? The CDC has an app and they have a vaccination schedule on it. And so you could always just look it up. I'll tell you in a minute. So if a woman comes in, and we always do check for HBV, the hepatitis B, if she has been exposed in the past, we draw titer levels. Hepatitis B surface antigen. We'll draw that one. If it's elevated, that means she's got active disease. Okay. You're not going to have to know that. Hepatitis C now, we're getting really good control of hepatitis C. I don't think there's a virus or a vaccine for this. I'm not sure now. I need to update myself. Let's see. Hang on, I'll tell you in a minute. Vaccine schedules. Wish it would let me search. Here we go. Okay, so hepatitis, actually, before they go home from the hospital, they get their hepatitis B. And then they get a second dose at 1 or 2 months. Just so you know. And HIV. HIV, as you know, we talked about this in class. HIV is treated during pregnancy if the amount of virus, or we call it the viral load, is high enough that could cause transmission to the fetus. So we can treat with antiretrovirals to prevent that transmission so that she can have an HIV-free baby. Okay. And I have some stuff on Zika and stuff too, but I could go over that. Okay. So a lot of stuff. I know you're probably going to see more questions about contraception than anything else on the HESI. So be kind of familiar with the non-hormonal and hormonal methods of contraception. Any questions? kind of a boring week for most of you, huh? You'd rather do something different than this. Okay, well, thank you very much, everybody, and we will get the test results to you as soon as possible. So if you want to know roughly what you got, I'll give you a ballpark, or at least I'll let you know if you pass or failed. Okay,